A 44-year-old female presents with persistent wrist pain and numbness in the digits. I am showing you axial T1-weighted and T2 fat-saturated magnetic resonance images of the wrist. Describe the findings.
Okay, I see it. The magnetic resonance images demonstrate several classic features of median nerve compression. On the T2-weighted fat-saturated image, there is abnormally high signal intensity and enlargement of the median nerve. There is also prominent palmar bowing of the flexor retinaculum. High T2 signal fluid is seen surrounding the flexor tendons within the tunnel, consistent with flexor tenosynovitis. The axial T1-weighted image confirms flattening of the median nerve within the distal portion of the carpal tunnel. These findings are highly diagnostic of carpal tunnel syndrome.
What is the clinical role of imaging in carpal tunnel syndrome? And what are the characteristic ultrasound features?
Carpal tunnel syndrome is typically diagnosed clinically through physical examination, nerve conduction studies, and electromyelography. Imaging is reserved for atypical presentations, postoperative recurrence, or to rule out space-occupying lesions. High-resolution ultrasound is the first-line imaging modality. Key sonographic findings include a cross-sectional area of the median nerve greater than 10 to 12 square millimeters at the level of the distal radius, swelling of the nerve proximal to the tunnel, bowing of the flexor retinaculum, and flattening of the nerve at the level of the hamate.
I am showing you an annotated MRI image of the wrist from this patient. Identify the structures indicated by the arrows and discuss their clinical significance.
In that case, the upper arrow points to the swollen hyperintense median nerve, which shows increased T2 signal secondary to intraneural edema. The lower arrow indicates palmar bowing of the flexor retinaculum, which is defined as a displacement of the retinaculum greater than 2.5 millimeters past a line connecting the pisiform and scaphoid tubercles. These features reflect the increased hydrostatic pressure within the carpal tunnel. Following contrast administration, the median nerve may show intense enhancement due to hyperemia or complete lack of enhancement due to ischemia.
What are the common underlying etiologies that increase the risk of carpal tunnel syndrome?
Well, any condition that decreases the volume of the carpal tunnel or increases the volume of its contents can precipitate symptoms. This includes systemic diseases such as hypothyroidism, acromegaly, diabetes mellitus, rheumatoid arthritis, and amyloidosis, which cause soft tissue deposition or inflammation. Physiological states like pregnancy and chronic renal failure with hemodialysis are associated with fluid retention. Local mechanical factors include repetitive wrist movements, prior distal radius fractures, or space-occupying lesions such as ganglion cysts, lipomas, or anomalous muscle bellies.
How would you manage this patient as a radiologist?
Okay. As a radiologist, I would recommend correlating these MRI findings with the patient's symptoms and nerve conduction studies to confirm the severity of compression. I would suggest checking for any underlying systemic causes, such as checking thyroid-stimulating hormone levels or screening for rheumatoid arthritis. For initial conservative management, I would recommend nocturnal wrist splinting in a neutral position and local corticosteroid injections under ultrasound guidance. If symptoms are severe, progressive, or associated with thin arm muscle atrophy, I would recommend prompt referral to an orthopedic hand surgeon for surgical decompression, which is the gold standard treatment.